what might this look like in 5 to 10 years, and what's sort of the long game. And there are some people that are interested in scaling. There are other people that are very much interested in staying independent. And the beautiful thing about this is that when this is all said and done, there are a lot of different ways that this is going to look in a lot of different communities, and there is no right or single way to do this. So what we wanted to do is explore all sorts of options that people are doing around the country, and we brought in a team of people that are doing some really interesting and exciting and innovating things in space from various portions of the country. So we have a very distinguished panel that has volunteered their time to come with us, and so we're appreciative of them. You already recognize Dr. Hal, Clint Flanagan, and James Pinckney. So they're going to go ahead and kick it off from here. Appreciate it.
Thank you, Lee, and thanks for being here. I want those of you who were in the last talk with Dr. George, I want to thank her for acknowledging Hip Nation, which you're going to hear about in this talk, and that's why I'm here to talk with y'all. What I'd like to just share with you is that I've been involved in the DPC movement for a long time, since 2011 when Lee Gross and I first met, and that's one of the centerpieces of the Docs for Patient Care Foundation. And we heard about the Aikigi. Is that what the term of what is your reason for being? And my reason for being when I started Docs for Patient Care was to transform medicine, and we've had a hard time really doing that because of Washington and states, and so the best way to do it is at the level that this group is here trying to do, which is to do it, at the grassroots level in your offices. And we really thought that that's great, but that's only focusing on just one aspect of healthcare, and that's the primary care. And how do we transform healthcare entirely? It's by putting direct primary care together with the rest of the healthcare system, and that's what we spent several years brainstorming, myself and some people that have been involved in the free market movement, and that's what you'll hear about today. So my talk is how to transform healthcare from inside the exam room. Let's see if we can. So this is the healthcare system, and you can see where the patient is right there, and everything is interacting with the patient in a crazy kind of Rubik's or Rube Goldberg kind of way. And I like to look at it like this. This is the healthcare system. So I think this is clearly a broken system, and we know that the cost trajectory is just unsustainable. Employer insurance costs have gone up over 130% since 2007. We know that insurance premiums which are covered by employees, have gone up almost 200% in just a 4-year period between 1999 and 2013. 14-year period, sorry. We know that the average annual deductible since 2006 has gone up 400%, and over the next decade, it's projected to go up another 166% with no end in sight. And this is the curve that many people have seen. This is the bottom graphs show the inflation rate between 2000 and 2010 at 27%. Workers' earnings have just stayed ahead of inflation just a little bit, but the workers' contribution to premiums and healthcare insurance premiums have far outpaced both of those. Again, unsustainable. So we've been told that the number one cause of bankruptcy, individual bankruptcy, is personal bankruptcy from healthcare bills. We know that that's because the annual cost of healthcare per family has just gone through the roof. From 2001, an annual cost of approximately $8,400 to $25,000 in 2015. And you can see what the breakdown by drug costs are and employee-paid health care. It's the number one concern of businesses, as we heard from Mr. Bacot from the Rosen hotel chain, and it's just their number two line item after salaries. And with Hip Nation, we've had an opportunity to examine the costs of insurance for many businesses. And this is representative of one of the businesses that we priced out healthcare for, a 75-person business. And you can see what their healthcare costs have done between 2014 and 2018, and it's just on the wrong trajectory. It's unsustainable. And this is this was from their Humana increase over a 9-year period. And it's because insurance is at the focal point of this system, which we've heard talk after talk is something that we need to get away from. And we know from a famous quote by W.E.B. Du Bois that to whom you give your money is whom you give your power. Now, this is an ineffective business model. The patient, the physician, and in between there is the insurance company and the government, and the third-party patient model is broken. And I'm just going to fly through this because we've heard this in virtually every single talk that we've listened to this weekend. So this is just something that reinforces what we've heard. And this is the payment circle. So this is starting at number one, patient scheduling, going all the way through insurance verification and patient collection to all the way from claim submission, payment processing, denial management, AR follow-up appeal, and patient statements. And it's only here, right at step 3 and 4, that healthcare is given. Everything else is about insurance. So that wheel needs to be broken. So this is the view from the physician's office, where you have the employer now with the insurance company put in between the patient and the physician, and the third-party payment model. And again, you've heard this information multiple times. It is inefficient. It produces 4 to 5 FTEs per physician, with overhead costs running about 60 to 70% for the majority of physician offices. Patient panels of 2,500 for most primary care doctors, to over 20 visits per day, 12 minutes or less per patient, referral-based triage, and EHR is a billing model. It's not a patient care model, it's a billing software model. And it takes up 27% of the clinical work. Innovation is inhibited. And we know that this translates to more work per doctor and less patient care and physician burnout. And we've seen this. This is a famous slide that everybody who gives a talk on healthcare uses today, with the healthcare cost curve in the black line. The brown line are the increase in the number of physicians between 1970 and 2009, and the gold curve is the increase in the number of hospital administrators. And a Harvard Business Review study looked at this data, and they've discovered that only 6 of the increased number of people in the gold curve has anything to do with patient care, and this equates out to a cost to the system of $600,000 in labor cost per doctor. This is the current model that we operate under. So the premise, as we have heard again time and time again, is that this healthcare system is broken. It's insurance-based, and healthcare is what happens when you sit in front of your doctor, not anything else in the system. So why are we interested in doing what we're doing in Hip Nation? because, as we said, the current model is broken and in dire need of transformation. Healthcare costs are higher than necessary and going up. Patients are paying a greater share of these costs. Care is increasingly inaccessible. The model promotes coding and billing above patient care, and physicians are buried in paperwork with decreasing physician and patient satisfaction, and patient care, health care is declining, and it's not getting better. Physicians are burning out, and because of things like this, the AMA latest CPT coding guidelines, which all of you who have opted out of insurance no longer have to deal with, but those of us who are still tied to this are sadly are stuck with for now. And all of this, and healthcare is not getting better for patients. So our vision with Hip Nation is that we can create an innovative delivery model that is going to place the patient in the center of healthcare, improve the healthcare experience, improve quality, reduce cost, and place health insurance in its proper role. And there's a role for health insurance, but it's not first dollar out. It needs to be a role for insurance for the catastrophic stuff, and dramatically reduce the administrative burden while introducing price transparency and igniting innovation while bringing back the joy of practice to the doctors. And so this model, this is just the thing, what we've heard about. This is the direct primary care model that you all are practicing, and that's the center of Hip Nation. And these are the numbers that have been published about direct primary care, what this means for patients: 35% fewer hospitalizations, 65% fewer emergency room visits, 66% fewer specialist visits, 94% decrease in readmissions, increased smoking cessation rates, increased medication adherence rates, lower workplace absenteeism, and decreased employee stress and increased morale. And so these are the reasons why we felt that direct primary care was absolutely essential to fix the broken healthcare system and was a centerpiece in Hip Nation. And so Hip Nation is basically a healthcare ecosystem. We take great care to avoid the term healthcare network because that connotes insurance, and we want to stay away from that. What we've done is we've created a healthcare ecosystem where primary care is at the center of this model with the patient, surrounded by another ring. It's like the nucleus with a ring of neutrons and electrons, and the neutrons are the specialists, the electrons are the services that we can provide to the patients in our healthcare ecosystem. So how did this all begin? Well, like I said, we've been watching direct primary care grow for years, and we recognize the importance of it, the influence of it on changing the healthcare system. And so two doctors that have been involved in Docs for Patient Care with me sat around, and we created a consulting firm, actually, because we would go to meetings and we would be at meetings with these consultants who were being brought in by insurance companies and hospitals who knew nothing. But they were getting paid, and the consultants would ask us questions about, what's going on in healthcare, and we would have to teach them. And we realized, well, why don't we form our own consulting company, and then we can go in and be the experts. But sadly, when you charge somebody for what nobody wants to pay. When you get it for free, then it's very valuable. So we figured, okay, we needed to do something, and we decided that we would create a model to change healthcare. A very low energy kind of endeavor. Let's just change healthcare. But we felt like we could do that, and we spent about 18 months, the three of us. We have a fourth founder, who is a healthcare attorney, who told us what we could do and what we couldn't do, and what would keep us out of prison, and what was possible. And so, after 18 months of coming up with putting all the nuts and bolts together, we put this together beginning in June of 2015 and did our official launch in January of 2017, testing proof of concept, putting this network together, or this ecosystem together, with 2 primary care doctors, 2 direct primary care doctors, and specialists who shared this vision and were willing to accept significant decreases in their fees to see the patients that were coming from Hip Nation, negotiating the same kind of favorable arrangements that you all are negotiating with imaging centers, with laboratories, with pharmacy, and more, with healthcare clubs, with CPAs, with psychologists, giving them an entire network that's looking at not just their physical health and well-being, but their total health and well-being. And so the founding principles, when we came up with Hip Nation, we knew that we couldn't bite off more than we can chew. So we thought, okay, we can do this and start out with businesses. We heard already how businesses are hurting, and that's the target audience. They would be most receptive to having somebody come into their C-suite, and instead of telling them we can decrease or we can keep their insurance increase to just the smallest amount, we're doing you a favor. We're going to only increase your insurance by 10% this year. We felt we can go into their office and say, we can lower your health care costs by 20 to 40% and maybe more. And that was what we decided would be the winning formula. And we tested that out, talking to business leaders in Atlanta, asking them if this was a model that they would be interested in. And we got universal 100% acceptance, and just kind of kept us moving in the right direction. And the way that we did that was we went and we asked them for their claims history. We went to businesses that were self-insured, ERISA plans. And you heard about from, I think it was from Keith Smith, that 80% of the companies are self-insured. I don't think it's that high. When we looked at this, it was 40% of the companies in the U.S. were self-insured, and 60% in the Atlanta market. Now I think it's a little bit higher. I think it's exceeded 50%. But that was a great group to approach, and we asked them for their claims history, and then we started pulling out what would be included and showing how, if that was not something they paid for and this wasn't something they paid for, that we could lower their health care costs, and we showed them tangibly how much less they would be paying on health care. Not only that, but businesses reinsure. Businesses that are self-insured have what's called a stop loss. So if they are going to exceed a certain amount of money, they're reinsuring that amount of loss so that they don't have to pay for it. They're paying insurance to mitigate that risk. Well, if you never get to that stop loss, then their stop loss insurance goes down, and so they can save even more. So that was one of the founding principles. The other is that if we could give these businesses, their employees, better health care with a concierge doctor, somebody that they can access on a 24/7, 365 basis, this would, be a win for their patients, for their employees, for the satisfaction of their patients, for the productivity of the business. And what we could also do is give them better access to specialists. You all know sometimes it's impossible to get in to see a specialist. Well, we guarantee that these people will get to see specialists in a concierge fashion, just like they get to see the direct primary care doctor. So that was the model. What happened next? Well, in January 1st of 2018, Blue Cross Blue Shield left the individual care market in Atlanta. It left 40,000 people without any care choices except for Ambetter, Medicaid, or Kaiser. And so that was their choices. So we decided, okay, we can strategically look at this group and figure out how we can incorporate this into our model. And so what we did was we teamed with New Era, which is a subsidiary of Philadelphia Life, which is an insurance company that's over 100 years old. And this is the same kind of insurance that many of our parents had pre-1964, where it was like a contract. So if you go and you get a wellness visit, there is a schedule of how much they will pay you back for that visit. You get a wellness visit, send in a super bill, they'll send you a check for $120. You get a lab test, they'll send you a check for $40. Prescription drugs, send you a check for $30. And so if they're a good consumer and they go to the labs that we've contracted with, a CBC costs $2.50. They get a check back from New Era for $40. They have made $37.50 on that transaction, which they can apply to their insurance premiums or their Hip Nation premium. If they are a bad consumer and they say, oh no, we prefer to go to the big hospital in Atlanta because we know that that's a quality place, they'll charge them, $120 for a CBC, and they'll be $90 out of in the red out of their own pocket. So this is also promoting good consumerism. So again, this is just summarizing what I've just said, what New Era pays, to an example of what they're paying the patients when they submit a super bill to the after a service that they've received from our Hip Nation ecosystem doctors, and it is. The new we do not have a financial arrangement with them. We don't want that. We want this to be a firewall so that we're not viewed as an insurance company. We are simply giving them the opportunity, those who don't have catastrophic insurance, who have who are insuring those big ticket items, to have, we're showing them an option where they can go. We also promote the sharing ministries as another option. But New Era has been a good teammate as far as this is concerned. And this is just as a slide that shows you a comparison of what the costs would be for a patient in the single payer market, or an employer who's paying for their employees. For Hip Nation, which we have, it's called Primary Care Plus because it's primary care at the center plus. And so for a family of 4, the traditional coverage would be $20,000 per year. With our plan, it would be $11,700 per year. With a small employer, they can save about $30,000 per month for a business with 9 employees or less. For a larger employee with 75 employees, they can save a considerable amount. They can save over $250,000, and that's just in year 1. So the current status of Hip Nation. We established proof of concept in North Atlanta to see if this idea would work. We knew it would, but we had to prove it, and we did. We now have 12 primary care doctors, family medicine and internal medicine. in 12 separate locations around Atlanta. We have 9 pediatricians, 24 specialties are represented in Hip Nation, and we have a virtual multi-specialty surgery center with 9 specialties that are represented. And I say virtual because, unfortunately, 34 states have certificate of need laws, which make it absolutely impossible to construct a multi-specialty surgery center like the Surgery Center of Oklahoma. We got around it in Georgia because Georgia has a single specialty surgery center exemption. And what that means is that if you're a specialty, a practice, not a specialty, but a practice, you can open up a surgery center that's tied to your practice, and you can't get anybody else in your specialty in it. It's confined to your practice. So it's really relegated to the larger practices that can support the surgery centers. But we have 9 groups in our Hip Nation ecosystem that have single specialty surgery centers, and we're able to link them with transparent pricing, cash pricing, so that we can provide the same services that are given in the hospital-based outpatient surgery centers for anywhere from 5 to 10 times less than is being charged at the hospital down the street. And this is just a list of the specialists, the specialty care that we have represented in Hip Nation. And these are some of the member resources that we have available for the whole wellness of our patients, not just the physical wellness. So I'm going to stop there so we can try to stay on time. And I'll be available to answer any questions afterward if we have time or outside. Thank you.
So you're going to have to do it after me. That's all right. I was going to say right here.
Maybe while we're getting things teed up, if anybody has any questions right now.
I just wanted to add, everything you just talked about is exactly where there's about 4 segments in the self-funded insurance world that every doctor here should be looking at.
Probably
All
put
the
it in.
health
Actually, here we go.
David Jason's guy, Next Gen Benefit Advisors, Nelson Griswold guy.
Yeah, we're going to have to do it.
Q4I Intelligence,
We're good.
so probably
We're
the
good.
4 largest conglomerates of
We're
self-funded
going to have to
brokers
duplicate.
that are actively firing Aetna, Cigna, United, Blue Cross on all the plans, building stop-loss reinsurance, everything he just discussed. If you're a DPC practice, find out where those guys are, because they're the ones that are firing agents, are firing the carriers, just like you guys would, fire.
Can you repeat the second, third, and fourth one?
Health Rosetta, which is led by Dave Chase. David Conforno is one of the guys that you've probably seen speak. If you're listening to Z-Dog or any of those guys. He was at the Pinckney conference. Next Gen Benefit Advisors, which is led by Nelson Griswold. The other one's called the FIA Group. And what's the last one? Q4I, which is Kevin Trophy, is the guy that heads that up. But they're literally training agencies inside agency systems. It's going to be your easiest way to access the brokers that actually understand it. I don't know
Where was it?
about health insurance. So. Thank you.
Where's yours?
And just to let everyone know, we are expanding. We are not only in Atlanta, but we're in Macon and Athens, Georgia, in a month, and we're going to be going out of Georgia in the second quarter in 2019. So if anybody's interested, please talk to me. Tennessee is part of our plan.
All right, I think we're good to go, guys, for right now. We'll give it a try. So today I'm going to talk a little bit about craft beer, hip hop, rap, DPC, and employers. Showing this slide here because what you have is a lot of different craft brewers, and mainly these are out of Colorado. I like the craft beer industry on many fronts, and particularly I think it's comparable to what we're doing in direct primary care. So arguably, maybe you get a little better beer, number one. Number two, there's all kinds of different craft brewers, right? There's guys that have just a tasting room and have a few beers, and then there are guys like New Belgium Brewing Company and Oscar Blues that are all over the country. A little bit similar to us in DPC, right? Sometimes you have one DPC doc taking care of 400 or 500, and then you have a number of DPC docs in a bit of a community taking care of more than that. Not sure if anyone's familiar with where this is at, but this is Telluride. It's a Telluride Blues and Brews Festival. And one thing I like about the craft beer industry is they have this culture where they're tremendously accepting of one another. They brew their own beers, but then they also will come together for events like this and brew specialty beers. And it's this environment where you don't really see polarity. What you see is a lot of a really cool culture where they're accepting of one another, understanding of one another, and moving forward. And I kind of look at that craft beer industry again a little bit like that, like us, and you compare that with Anheuser-Busch, compare it with Miller Coors. It's a little bit more like United, Anthem, Aetna, right? In these guys, the craft beer industry is looking to really disrupt that space. Anybody know who this is? One? Two? Okay. Maybe a few others. So this is Run DMC. I'm not going to dive too deep into these guys, but they came out in around the early 80s, and they definitely pioneered and ran down a lane with hip-hop and rap that no one had really run down before. And they took a lot of flack in the early days for that, and they're legendary now, right? I don't know if they're in the Rock and Roll Hall of Fame yet, but they should be. So I'll get to those guys in a second. So I'm Clint Flanagan. I'm the founder and CEO of NextEra Healthcare. I've been a board-certified family medicine doc and ER doc in Colorado for over 15 years. And on our pathway, very early on, I was involved in a multi-specialty group as a primary care physician. From there, went to work for the largest provider of healthcare in the state of Colorado, doing primary care, and then got down a path where I just really wanted to own my own primary care clinic. So moved forward on that front. We had a couple of clinics in the Longmont, Boulder, Colorado area. And through those experiences, both in family medicine and emergency medicine, just saw so many barriers that many of you are very familiar with. And as much as we owned North Vista Medical Centers, and we had a couple in the area, we just really realized that the model wasn't right. The model for primary care in this country wasn't right. So in about 2009, we said we're going to do something different. And at the time, I didn't even know what direct primary care was. So we started down a pathway. We called it monthly membership medicine or monthly membership healthcare. And as we were moving down that pathway, I connected with Dr. Garrison Bliss. And I'm like, Garrison, you're doing something very similar to what we're doing, and you happen to be coming to Denver here in a little bit. Can we go have some dinner? And it reassured us at the time, because remember, it was a proof of concept. We were a startup. It reassured us that, hey, there's another guy out here doing this, and he's also got some investors investing in what he's doing out in the Seattle area. So we started down that pathway. Again, had a legacy fee-for-service practice. That business, it was surviving. It wasn't, I wouldn't quite say thriving, but we were paying bills and moving forward, right? So we owned a private primary care practice with thousands of patients. At the time, we did not want to offload that. We did not want to shut that down because we had staff, nurses and MAs and front office staff. We had patients that we were seeing. And again, we were doing this at a time where not many people in the country knew what direct primary care was. In fact, we spent a lot of time talking about how we're different than concierge medicine because that's what they thought we did. So started down that pathway very much with the idea of we want to take care of patients, families, we want to take care of our communities, and we want to take care of employers. So very early on, that was a target for us to move down that pathway and help our communities because we saw them struggling on many fronts. So why? Hal kind of got into this a bit. This is the Milliman Index for a PPO plan for a family of four. So as you can see, it's $28,000 or so in 2018, right? And an employer is paying a big chunk of that. So that's obviously unsustainable. This is very similar to Hal's graph. You can see here, general annual deductibles for covered workers have increased 8 times as fast as wages. Okay, unsustainable. This chick came out of SHRM here recently. Employers adjust health benefits has cost near $15,000 per employee. So oftentimes the second highest cost outside of payroll for a company is their health coverage or benefit. And I thought the gentleman from Rosen did a phenomenal job of explaining this yesterday. So as I mentioned very early on, we wanted to help employers. We're big fans of small business. Whether it was a company of 5 electricians or 20 plumbers, whether it was a HVAC company, that was our target. Those were people that we wanted to take care of. And many of them had zero health benefit for their employees. And this is at a time when the unemployment was quite low, and it's even lower today. So you have owners of companies wanting to provide some kind of benefit to their employees, and unfortunately, things were quite expensive. We would come in and say, hey, it's up to you, the owner. You can decide whether you want to pay the full amount yourself, or you can pay 70% of it and pull the rest of it out of your employee's check. So for us, this was a natural direction to go. Why? Because there's 156 million Americans at least that get their coverage through their employer. About 40-some million get it from Medicare, 62 million get it from Medicaid. Then there's the uninsured and non-group. So that green piece is a piece that we are very interested in. Plus, we just essentially felt obliged to take care of our communities, and knowing that a lot of those employer groups were providing some type of benefit, it was a natural direction for us to go. Many of you have likely seen this, the cost of poor health to employers. There's the personal health costs. The iceberg beneath is absenteeism and presenteeism. And as you kind of dive in over here, overtime, turnover, admin costs, off-site travel for care, so employees leaving the campus to go get care elsewhere, consumer dissatisfaction, etc. And with regards to employees, as you look at premature death, about 40% of that is behavior. Okay, it's related to their smoking, their drinking, they're not getting sleep, et cetera, et cetera. About 10% or so is genetics, environment's a chunk, socioeconomics is a chunk. So understanding this and understanding a big focus of what we wanted to do was be proactive and preventative, we said we want to come in and help employers on this front. So what are the top 10 health conditions driving costs for employers? Depression, obesity, arthritis, back pain, neck pain, anxiety, GERD, allergies, cancers, chronic pain, hypertension. These are all things that are within our wheelhouse, right? The challenge is patients don't have access. It's really hard to get in, and or it's very costly. So at NextEra, we said, hey, not only do we want to provide you a better experience than what you're currently getting, we actually want to help coach you to optimal health. So in our mission statement, it doesn't say we want to provide sick care. That's what the majority of our healthcare system looks like. It's really not a healthcare system, as you may have heard. It's a sick care system. So you've heard the example of, it's like a gym membership, right? So if patients are paying that fee, we want them actually to come in. So we're having a whole discussion with these employees and patients about this is a bit different than what you might have been used to seeing your doctor once or twice a year. We want to actually be your partner and help you optimize your health. This is a busy slide, but there are 2 things I want to point out. And one, better health. Evidence shows the access to primary care can help live longer, healthier lives. Check. Number 2, U.S. adults that have a primary care physician have 33% lower health care costs. So we can make a huge impact. Without that, you get fragmented care. Fragmented care, more specialists, higher costs, more tests, inappropriate referrals. Healthcare costs are higher in regions with higher ratios of specialists to generalists. So this is stuff that a lot of us know. And how much can be saved of that 3.5 trillion pie? About at least $1 trillion. So this is sources of waste out of the Institute of Medicine. Unnecessary services, excessive admin costs, et cetera, et cetera. Who better to help our patients navigate this than us, right? Your broker's not going to do it. The HR director is not going to do it. The insurance plan in their app kind of say they might do it, but really who better to help patients navigate through this? So many of you have heard of the Institute of Health's triple aim, okay? Lower cost, better outcomes, improve patient experience. Been talked about for a long time. Then there came the quadruple aim, which if you're going to design a model, hopefully doctors like it. That's the problem, is people forget about us. So that's why there's a big red arrow that says, hey, we better like this thing. And then the fifth piece, that's we have to give courtesy to Dr. Frank Reed out of the University of Montana, is a competitive business advantage. So meaning that if you, as an employer, bring in one of us, you are going to have a competitive business advantage against other employers in your area. Why? Because it's going to be making, hopefully, an impact on absenteeism and presenteeism, health and wellness of your employees, as well as spend. So how are we going to do this? So I kind of talked about the why a bit. Then there's the how, and the next piece is going to be employers and results, okay? The answer is obvious to a few of us, maybe most of us in the room. We're going to do this with direct primary care. A model designed by physicians for patients. Okay. Harvard has this great little article out of 2015, Strong Patient-Provider Relationships Drive Healthier Outcomes. They actually featured DPC in that article. So most primary care docs are this, stiff neck, blurred vision, carpal tunnel, all due to extended time in front of a computer. I think I just discovered the ICD-10 code for my job, right? That's, and I used to kind of be one of those. I used to see 30 patients, 35 patients a day. And it's, I would probably add mixed anxiety and depressive disorder to that as well. It's very, very stressful. And so, versus what are we? Superman and Wonder Woman. Okay, us DPC physicians, this is Dr. Garrison Bliss and Dr. Erica Bliss. This is Dr. Rashika Fernandopoul with Iora and Dr. Lisa Davidson. This is Dr. Ryan Newhoffel and Dr. Julie Gunther. So this is what we are, guys. And why? I think this slide, at least for me, encapsulates why we're doing what we're doing. Okay? So you have mom and dad with baby, and you have doctor. And even the baby's looking at the doctor, right there. It's just intent, right? That therapeutic gaze. It's time and a relationship. And many of us struggled for years trying to get to that. But when you're seeing 30 patients a day, it's really hard, right? Maybe you can talk about an earache, but what if dad has some insomnia and mom's depressed, and the things we do in family medicine, I really think this slide encapsulates it. The challenge is the business model. That's the dirty secret they didn't tell us about in med school and residency. Oh, by the way, the model's not a model anyone would sign up for. So what do we have here? With DPC, the employee, the patient, right? You have your wellness care, primary care, access time, care coordination, televideo visits, weekend hours, all the things that we do, impacting acute care as well as chronic care. The many direct primary care services out there, you guys are familiar with these, I'll kind of fly through that. Having that DPC doc be the quarterback, you'll see less ER visits, less urgent care visits, more continuity, more connectivity, higher seamless quality experience, more proactive versus reactive care, peace of mind. And what do employers want? So this is pretty new here. Top initiatives for 2019. Add more virtual care solutions. Okay? You see companies doing this with Amwell and Teladoc, baking it into the plan. That's okay. Maybe it's a step up, but I would argue that having us on board with that patient for telemedicine is much different because it's the doctor they know versus a doc in a box they don't know. Focusing strategy on high-cost claims, expanding centers of excellence, helping with pharmacy, adding a consumer engagement platform. Some of this stuff is fluffy stuff. I'm like, just get a DPC doc, right? I like the bottom one, though. Implementing high-performance networks. Now, again, as Hal said, networks is an insurance term or so, but who is more high-performance than what Hal's talking about or what we're doing or what James is doing, okay? That's high performance in my opinion. And employers want that, okay? They want that, and they're willing to pay for that. So on our pathway, what do? Okay, we wanted to, you see that term network, and I prefer, ecosystem or community, but we said early on, hey, if we want to take care of employer groups, we got a couple of clinics, we're going to need more, right? We're going to need more clinics, more docs to help us out in zip codes where we're not. So we started saying, let's do that, okay? Let's find docs. And again, this is at a time, guys, when we were the first DPC in Colorado, so there were no DPCs outside of us. So we were going to our friends that we knew that were great private primary care doctors, going to them and saying, hey, listen, we'd love for you to be a part of what we're doing. Can you take a risk? How many patients do we have? Hardly any. But will you just come on and let's do this together, right? Get in the boat with us. Set up agreements. One thing we said early on is, my gosh, we could do on-site clinics. You know, when you approach a company, like one of the companies we approached years ago, they're a $3 billion company. They spend over $20 million a year in health benefit, and they had no on-site clinic. Smart company, right? And we said, hey, you got a huge space. We'll come in and be your doctors. And we'll come once or twice a week, whatever the demand is, and we'll charge you $0 for that, okay? So that was one of the things, being agile and flexible to meet these employers' needs. And they love that. And now we have, for that company, I think 7 or 8 locations, and we've got 3 or 4 on-site clinics. Going out, getting to employers, you know, some of the most fun employers to go do business with are small companies, less than 30 employees. You know, you meet the owner, you talk to them, and they're like, yep, I love what you guys are doing. You shake hands, and next month, you know, they're signed up. You know, we've had some turnaround times with small employer groups of like 30 days. Versus larger employer groups can take some time. So you can go directly to them, whether you're going to chamber meetings, whether you're going to Rotary meetings, et cetera, et cetera. You can talk to your patients that might own businesses. You can start to navigate this quagmire of brokers. We've been doing it for a lot of years, and I think maybe as David Chase had said, you know, there are few of the enlightened, maybe 2% out of 100 that get it. And then of that, maybe 0.5% will actually produce, right? So moving through brokers can be challenging, but it's kind of needed because many of the employer groups are really tied to those brokers. So find some friendly brokers, start talking to them. You also need, with employers, at least in the state of Colorado, because the direct primary care bill, you need to have an employer agreement. And how do you make this happen, right? You see me up here today, I have a team of wonderful people, right? I lead as the CEO, we've got operations, CFO, we have legal counsel helping us on this pathway, marketing, director of employer engagement, so we have a person that's one of her jobs is to actually, to bring the employers to us, and then from there the baton is handed. Once the employees sign up, there is a continual process all year long where we're emailing, calling, reaching out to employees because we want them to come to the gym, right? And if their employer is paying for it, we for sure want to provide some value. Nursing manager, front office manager, it takes a team to make this happen. And it's a lot of fun, and we built this. Anybody familiar with this guy? $20 if someone knows who this is, or at least a beer. This is Dale, okay? Dale Ketchkiss. He is the owner of Oscar Blues. And Oscar Blues is a company that makes craft beer out of Longmont area, and they also have some restaurants and things. And he is an awesome guy. His building where he makes that beer is about 2 minutes from our office in Longmont. And what I love about it, as you drive by the building, and this is just one little slice of it, it's a huge building, it's Oscar Blues Brewery, anti-corporate headquarters, okay? So you hear this term corporate tossed around, and corporate, you know, what we're doing is not synonymous with United, Anthem, and Blue Cross, guys, okay? We are a group of private primary care physicians that do DPC and or are fee-for-service docs taking care of people, and the furthest thing we're away from is corporate. Okay, I used to be in that with the largest provider of healthcare in the state of Colorado. And those things can get in the way of patient care. They can get in the way. And so we want to make sure that things aren't getting in the way of patient care. And Dale is a righteously independent guy. And I love it. So what have we done over time? We have a number of locations now. I think we're at about 45 locations. We're in about 8 states or so. As you look at the physicians in our NextEra community, they have about an average of 20 years in medical practice per physician, okay? So super experienced docs, and most of them have been in the fee-for-service world for years, and they own their own practices. As I mentioned, we have about 19 or so locations in Colorado, including on-site and near-site clinics, and then 20 locations elsewhere. We go where our employers ask us to go, okay? If we have an employer group of 400 to 500, we will deploy to them, it doesn't matter, and then we look to find a doc, which, by the way, if there's anyone here from North Dakota, I need physicians in Williston, North Dakota to take care of oil and gas guys. So if you know anybody up there, please let me know. It's a bit of an interesting place. But the company is located in Fort Collins. So they want to take care of 200 oil and gas guys up in Williston, North Dakota. And there's 2 states left that have no DPC, North Dakota and South Dakota. So maybe we'll break into that. So as you look at the cross-section of who we are, 55% of our docs are DPC docs. Okay? They own their direct primary care practice like Dr. Philip Rhodes. So Phil's here in the audience, and he owns his DPC practices, opened it in January in Loveland, worked at Banner for years, and now owns his own DPC. And it worked out for us well. Phil was starting, and we had a trucking company with a number of truckers that were right in his zip code. And so as he started January 1 of this year, we came together, and he's now offering care for truckers in the Loveland area. So it's worked out well for both of us. It helped him receive some monthly revenue for employees, number one. And number two, it helped us because we needed a doc there. Greater than 99% of our patients' members are attached to a physician. So who do we take care of? A lot of the different companies that we take care of are listed right here, from plumbers to municipalities, ballet companies, craft beer companies, churches, skincare companies, attorneys, you name it. We want to take care of our community, and this is our community. I'm going to fly through here. So Grover Ray, he is a senior level CHRO of Digital Globe, and said we're continually striving to be the employer of choice where we work and live. Okay? And he wanted more than what they were getting. Again, this is the company that's spending millions on coverage. And he realized that there were inefficiencies and flexibilities in systems, and he said, hey, we want something better, and we know that there's a shortage of family medicine and primary care docs, so we're going to step into DPC. His colleague, Angela Hopkins, said, hey, I wanted more than just a Fitbit for wellness. You hear all this wellness stuff. Who better to do wellness and help companies out than us direct primary care docs? So results, and I'm about done here. On the results front, this is on our website. It's a case study that we did with Digital Globe, and we show we decreased their downstream claims by about 25.4%, and after they paid us, they still saved about 14%. In the Denver Business Journal, they reported $1.3 million is what they saved this last year. Employees can get in faster, and they're not paying stuff out of their own pockets. Left Hand Brewery went from a fully insured model to a partially self-funded, level funded. They pay for the good majority of the membership. Most of their employees are on NextEra, and less claims were hitting their plan, which resulted in improvements in their premiums year in and year out. We spent a couple of years getting this contract. This was St. Vrain Valley School District, the school where my kids go. I have 3 kids that are in this school system, and they are self-funded, and they jumped into the arena with us, and we've been taking care of them since January of this year. They baked us into a UMR direct care plan. So their TPA, United Healthcare UMR, the left column over there is NextEra Healthcare, and you can see preventive care covered in full, primary care offices covered in full at NextEra providers. So this is the way a plan looks, and it's better to bake yourself into a plan than be separate. Okay? Just try to push yourself right into that, and that makes it one line item essentially. For years I've been saying your insurance card does not equal health care. Okay? Insurance card doesn't equal health care. And we're like, our marketing team's like, well, why don't we see if we can get on the insurance card? So we did. This is the card the schools, the St. Vrain Valley teachers get, and right there it says NextEra Healthcare. So just ask, what did it cost us for that? Very little. I think our marketing guy just sent a vector file to these guys and get your name on the card, right? So they know. And it's called the UMR Direct Care Plan. What did we do in the first quarter? We saved almost $400 per employee per month. Okay? And if you do some easy math, if it's 500 teachers on this, saving $400 per member per month, that's $200,000 a year, $200,000 a month, $2.4 million a year. Okay? And we can pay our teachers better and hire more teachers. What's in it for me? The answer to this is really good stuff. Just give employees your direct primary care. I'm going to fly through this to get James up here. All right, let's see if this can happen. All right, so down this pathway, I'm back to Run DMC. I thought it'd be kind of fun if we could just do hashtag Run DPC, and for the guys in the crowd that know these guys, they have a fun song called Tougher Than Leather.
It's tricky to rock a rhyme, that's right on time. It's tricky. Tricky, 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 tricky. What up, Notorious DPC? It's your boy Z-Dog MD. Hey, mad props to all y'all getting tougher than leather, building that health 3.0. You know what I'm saying? I don't even know what I'm saying, honestly. Run DPC for life. We out. Peace.
So a few of you are probably familiar with that guy. He's awesome. He's a great champion for us, and it's good to have a guy that's got that kind of stage that is promoting DPC across the country. Okay? Good physician treats the disease. Great physician treats the patient who has the disease. I show this a lot, and that's what we're doing at DPC, guys. So I thank you for your time. I'm sorry if I took too much of James' time, but we were pushing it in, and we're happy to answer questions after we're all done.
So we didn't see each other's presentations, but the order was perfect. You know, Hal gave a great background on the broken healthcare system, and Clint just gave us some great information on what he's doing at Nextera. So what I want to do now is talk to you guys about the future of DPC and where I'd like to see the marketplace going and what we're doing at Diamond Physicians. So a little background about myself. James Pinckney. I'm a board-certified family physician, CEO and founder of Diamond Physicians, and I started my medical career as a general surgery resident at Cedars-Sinai in Los Angeles in 2008, and quickly found out that the life of a general surgeon is not great, and decided that I was going to switch to family medicine after I got my first taste of concierge medicine at Cedars, and I said, wow, what an incredible model, but how can we make it affordable for everyone and not just the super wealthy? So I switched to family, came back to Dallas, where I'm from, in 2009, and actually met Clint in 2010 at a conference and confirmed that I wasn't crazy because he was doing a similar model in Colorado. And then one other thing that I did when I was in residency was I started a geriatric house call company for a resident that was graduating that didn't have any business background. And that gave me a lot of experience on how to run a practice and really gave me an in-depth look into the insurance billing system, specifically Medicare, and confirmed that I did not want to enter into that system. So in 2012, directly out of residency, we launched Diamond Physicians as an organic launch, no existing patient panel. We did it from scratch. And the first 2 years were very challenging. We made a lot of mistakes, and it was around 18, 19 months into this thing when we were on a national Vistaprint commercial that you may have seen. It ran all over the country. We had 2.9 million viewers on Monday Night Football, and 180,000 people come to our website within 18 seconds after the commercial ran. And it really was a launching point for us. So now, fast forward 5 years, and we have 3 locations in the DFW Metroplex, 5 docs, and over 2,000 members. And we are launching a pediatrics practice next week. So we have a pediatrician joining our practice. We're really excited to welcome her to the Diamond family, and we're going to have Diamond Pediatrics, so we're excited about that. So what does scaling mean? Well, Webster defines it as to climb to or over the top of a high, steep object, such as a mountain or a wall. So my goal is to create an environment where every DPC doc, no matter where you are in the country, you can be successful, you can thrive, to make DPC ubiquitous. And in order to truly transform healthcare delivery in America, I believe we have to create a system where no doc can fail. So how do we make DPC sticky? Number one, I'd like to create a free market portal for consumers to purchase DPC seamlessly. I think that would be great. And number two, create an environment where employers can provide DPC to their employees seamlessly, something very similar to what Clint just spoke about. So from a free market individual marketplace standpoint, in 2019, the individual mandate was lifted. And President Trump, actually, you know what? This is based on I'm not seeing my notes here, so I need to do something different here. I think we duplicated the screen for Clint's.
Good old Clint, huh?
Screwed things up. Instead of projecting the screen. Extend, yeah. All right, perfect. So what if we could service millions of Americans with an affordable insurance product coupled with DPC? You know, I dreamed about this concept when I first started my practice 6 years ago, and it really was a manifestation of how hard it is to reprogram the way individuals that come into your office think about their insurance product. So I would say, you know what, we don't take insurance. We are a membership-based practice, because remember, DPC, that word didn't exist when I started. We offer unlimited visits, no copay, 24-hour access to the doctor. You can call my cell, you can email me, you can text me, and unlimited urgent care. And they'd say, do you take Aetna? I said, no, we don't take insurance. We offer unlimited visits, go through my spiel again, we give you great cash pay discounts on labs and imaging, and they say, well, why don't you take insurance? So it's very challenging. So I was wondering, what if we had this, this portal that we could utilize to really fill practices more quickly. Something that could combine DPC and a catastrophic short-term limited duration product, something that we talked about yesterday. I think that would be incredible. And then, once this individual mandate is lifted on January 1st, 2019, millions of consumers are going to have the opportunity to purchase a truly comprehensive product. They won't have to be limited to healthcare.gov, the Affordable Care Act, very expensive gold and silver plans. So imagine an exchange where you have two versions of DPC. One version is the version that we all offer in our office, and the second version is a telemedicine version that Clint kind of touched on. Something where it's not a 1-800 number with a queue, but it's that same provider every time that presents continuity of care. I think that would be incredible. Well, that's exactly what we're building at Diamond. It's called the Diamond Direct Care Network, and it's not a healthcare insurance network. It's a network of us. It's a network of physicians, and I love the term ecosystem. That's great too. But essentially, it's created and operated by Diamond, so there's no outside funding, no corporate pressure, no investors to increase profit margin. It's just a DPC doc trying to fill other DPC doc practices, and that's what this should be about. It should be about patient care and giving the best care to our patients and filling our practices quickly and efficiently. So you can use your own EMR, use your own processes, your practice remains autonomous and independent, but it networks us all together. Another great thing about Diamond Direct Care is that you can actually, you have a dial to control how fast your practice grows. So if you are an existing practice that is almost full, you can say, look, I only want to take 10 patients from the Diamond Direct Care Network. Or if you're a new physician who's just joining the DPC movement, you can take 300 patients. Or if you're adding a provider, you can tweak that dial to exactly your need. No cost to join, absolutely free, and it's non-exclusive, which is very important. So if you want to join Hip Nation, you do it. If you want to join NextEra Healthcare, you do it. And that's the way these networks should be built. They should be free market. The only caveat is that you have to be a pure DPC. I know Clint has some hybrid DPCs, but in the Diamond Direct Care system, we're only utilizing pure DPC practices. If you are transitioning your practice and you are still taking insurance, you just have to promise me you're going to be pure DPC at some point, and we'll shake hands, and you can come on into the network. So what we did is we partnered with Allied National, who is actually the largest wholesaler of short-term limited duration products in the country. They sold 60,000 last year. So it's going to be very exciting as these new consumers flood into the marketplace in January 1. That number is going to increase exponentially. So we have an online portal, and the consumer logs on, and they can pick an insurance product. It's not just Allied. It can be an indemnity plan, some that Hal talked about. It can be health shared ministry. We want a free-flowing system to where the consumer can see all these different catastrophic backdrops and choose the one that's best for them and their family. And in the case of Allied, there's a questionnaire that's online. They fill out the form. It does take into account pre-existing conditions. So if they fill it out and meet the requirements, then they're instantly generated with that health insurance product, and then they're directed to another portal that allows them to choose a DPC physician. So the profiles are there, they type in a zip code, and they can choose one of you guys. And the next piece is that DPC telemedicine piece that we just spoke about. And essentially, what we did, we created a product called DrLink. We did it in-house. It's also free, comes with the network. And what that allows us to do is actually expand the footprint of each DPC practice. So there's a lot of consumers out there that are either in rural areas or remote areas and maybe hundreds of miles away from one of your practices. Well, with Dr. Link, they can actually receive the exact same care, no inpatient visits, but they have that continuity of care. They can use the app, the video conference, text, and things of that nature. And then they also get the cash pay discounts with labs and imaging as well. So it's a great way to connect to people, not just 30 or 40 miles around your practice, but to the entire state border where you're medically licensed in. So now we talked a little about the individual marketplace. Let's jump over to the employer space and talk about how complex that environment is. Clint touched on a lot of these topics, so I'll reiterate some of his sentiments. And one of them is it's extremely long sales cycle, so you have to plan for that. We have one company where literally we've been talking to them for 5 years. The CEO and the CSO, Chief Strategy Officer, are clients at our Dallas location, and they keep dragging us along, and I keep going with them. Maybe one day they'll decide to put their 2,000 live company on the platform. And then it's also challenging with human resources, the C-suite, and brokers that aren't innovative. So we were pitching a municipality in the DFW Metroplex, a very large suburb. I had the mayor, the city planner, and some other high-ranking officials, and the broker in a room, and we were giving a presentation. And literally, during our presentation, I was explaining DPC, and I said, we offer 24-hour access to all of your staff. And she was like, no, you can't do that. That's impossible. And I looked at her, and I said, we've been doing this for 5 years. It's very possible, it works, and it's an efficient business model. So it's hard to overcome those brokers that just don't get it. I think someone mentioned the Rosetta, Healthcare Rosetta, and those are a great group of brokers that get it and are willing to work with you. Battling that status quo, it's hard to reprogram the way people think. And then, unfortunately, BUCA, Blue Cross, United, Cigna, and Anthem, they pay huge commissions to these brokers. So you're going to have to overcome the fact that if they do transition to a DPC wraparound product, they might be losing a lot of commission, and that's something that you're going to have to overcome. Claims data. Clint also talked a little about this. It can be hard to track down. So what we do is we try and collect 2 to 5 years of claims data for a company, and we'll do some analytics on it and then pull out the CPT codes for ER visits that don't result in hospitalization, urgent care visits, labs, and things that we can affect, and be able to tell the company exactly how much money they would have saved if they had Diamond during the course of the claims data that we collected. And typically we even baked into our cost, can still save them money or at least come out cost neutral. So the Diamond Direct Care Network is designed to offer DPC to large and small employers, unions, independent school districts, via telemedicine, in-person visits, or both. And what it does, it improves the ability to close contracts with employers who have employees in more than one geographic location by providing a heat map. And that heat map is critical for the sales process. I've gone into so many meetings when I had 1 location and 2 and 3, and they kept telling me I didn't have enough coverage. And I'm like, well, how much coverage do you want? So if you can go into a meeting with an employer group and say, hey, look, I'm part of the Diamond Direct Care Network. You can use us, you can call it what you want, and say, look, I've got doctors in Denver, in Miami, in Dallas, in Detroit, and that will actually help you with your sales process as well, closing out some of these employer accounts where the geographic locations are spread out all over the country. So how does it work? Well, our very first large employer client was a company called Ameriflex, and the CEO, William Short, he just gets it. Both his parents are doctors, and I thought employer sales were going to be easy because he signed up in one of those 30-day type duration periods, but the next 200 people were very challenging, and it didn't look like that. But as our relationship grew, I started telling him about some of the challenges I was having with closing employer accounts, and he said, well, we process payments for a living. That's what Ameriflex does. That's what they do. They process HSA and FSA payments. They have about 70,000 employers that they service. So he said, why don't I spend my money? I said, that's a great idea. Spend your money and figure out a way to help aggregate all of these employer payments and employees and do all these things that can make your life a lot easier. I said, great, go for it. So that's what he did. He created a company and a system called Acressa that streamlines and aggregates payments from various sources. So let's say you have employer A, and they have 1,000 lives spread out all over the Metroplex, and they subsidize the DPC membership by 50%, and the employees will pay the other 50%. And you have employer B that wants to subsidize their plan by 80%, and they have 500 employees and 250 in another state. And then you have employer C with 2,000 employees, and it's a voluntary benefit, and they're spread all over the country. Well, that's a logistical nightmare to try and aggregate all those payments and keep all those things straight. And that's what Acressa does. So they aggregate the payments from many different sources, and they pay you, the physician, once every month, and you have a dashboard that can look at all the payments and how it works. It's very price transparent. So that's what we've done, and I think it's a great way for employees to choose the practice and remain a free market system, because you actually put your services that you offer on your profile. So to recap, the Diamond Direct Care Network, it's a free market network of DPC docs that connects independent practices to employers of all sizes. We currently have 42 physicians in the network across 15 states, but we're going to need a lot more. Right now, I am talking to large healthcare systems, one in California with 300,000 lives. We are very close to securing a pilot with a bank, and this bank, we use the tactic of JP Morgan Chase, Amazon, and Berkshire Hathaway. They are creating a healthcare conglomerate to take care of their employees, and Amazon is doing a DPC pilot in Seattle. So this is coming. And we said, look, do you guys want to get ahead of this thing, or do you want to be left in the dust? So that's been an effective strategy for us. And then we're talking to a transportation union as well with 600,000 lives. So if we close one of these large accounts, we're going to need everybody in this room, and Clint and Hal and everybody else in the country that's doing this. And this is exciting, and this is the future of healthcare in America, and this is where we're going. So if you want to take a look at the consumer-facing portal, it's at get.diamonddirectcare.com. And again, we are the solution. This is a quote from Malcolm Gladwell, one of my favorite authors, from a book called Outliers. And it says, if you work hard enough and assert yourself and use your mind and imagination, you can shape the world to your desires. And that is 100% true. So thank you very much. I think I made up some time there so we can do a Q&A.
What time? I think we.
So this is the most important question I ever asked. She said yes. So questions for me, for Hal, for Clint?
Hi, Steve Baker from Vancouver, Washington, launched 3 months ago, my DPC. So many of us are beaten up and bruised by the fee-for-service system. That's why we became DPC docs. So maybe you guys could explain a little bit how being a part of your ecosystem isn't just joining another system that could become something we regret versus something that's physician-centered. And also, I'm curious, with each of your 3 ecosystems or networks, how is a physician, how does a patient pay the physician, or does it go through your network to the physician?
I'm happy to chime in on that. Is this, you guys hear me? And sorry, maybe I kind of blew through my slides a little bit, but so remember, for me personally, I worked in a multi-specialty group, 50 docs, and after 3 years of working for them, despite making a lot of money and having a brand new clinic and having a great patient panel, I quit, number one. Number two, I worked for the largest provider of healthcare in the state of Colorado, and I left them. So I, like many of us in the room, and like most of our next era physicians with average of 20 years of experience as a physician, you know, we have, I call it, you know, stripes on our shoulders, battle wounds on our bodies, and scars from this system, right? The last thing that I would ever want a next era physician to feel is like they're in some kind of model that is burdensome. On the flip side of that, when you're a new DPC, and I'm not, You know, when we started in September many years ago, I'm like, we're going to have 500 patients by December. This is the best idea in the world, and here we go. Get ready. Yeah. Did not happen that way, okay? So I'm not naive to the fact that, especially for solo DPC docs out there that are starting, you have bills to pay. How are you going to do that? You know, what's your side hustle? You're going to be a hospitalist, you're going to do urgent care, you're going to be a medical director. What are you going to do, right? Until you get up there, I think every doc in America should be paid over 200 grand. We just hired 2 doctors. One was a hospitalist for Centura. The other was in practice for 20 plus years in Boulder, had been in many different systems, and we create pathways for patients, doctors, whether we employ them, number one, or number two, whether they're an affiliate, which are way better pathways than where they've been. And part of the reason I'm pretty adamant about that is I'm on that pathway too. So I have a full panel of NextEra patients, and the way the payment works is we invoice our employers. Okay, the employers pay us, we pay our doctors, we take a percentage off that to pay for that team that I just talked about that does the heavy lifting to get the doctors, that our team that does the heavy lifting to get the employers onto NextEra. That's not without a lot of work, and I don't know that all of us are willing to do that work. Okay, a lot of us just want to do the doctoring piece of that. So I would say if you look at anything, look at our retention rates over 97%. Patients that leave us don't leave because they don't like their doctor. They leave because the employer, they've left their employer, number one. Number two, feel free to talk to any of our affiliates, from Dr. Eric Krall down in Tampa to Matt Hayden in Virginia to Dr. Gibb up in Buena Vista, Colorado. You know, we're writing checks to our affiliates that are $3,000, $4,000, $5,000, $7,000, $8,000 per month. You know, and that helps you pay the bills, right? And there's enough DPCers out there now that you're hearing these pain stories of how, gosh, I think it's a great idea, but I can't get enough membership, right? You got to get out there and hustle and work hard and sell, which a lot of docs just don't want to do a lot of that. So we are very open as well. We're not perfect in what we do, but we've been doing it long enough that we've made enough right plays in our playbook, and what we are very open to is helping all of us as we move forward. So when you have that amount of physicians, you have leverage with accounts like LabCorp and Quest, leverage with imaging companies, leverage with hospital systems, where we can come in and start to say, hey, listen, can we negotiate some things? And so that's the other beauty of being in a larger group, is there is this power, right? And years ago when I went to the radiologist group here in town, and I said, hey, can you give me some transparency on MRI pricing and CT scans? You know, this is like 8 or 9 years ago. They're like, excuse me, what? So kind of a long answer to your question, but it's very, very important for us. The last thing I would want a NextEra physician to feel like is they're in the system, right? That's wrong. So I'll give you one quote. Dr. Tim Nagel, who's a doctor that is employed by NextEra that works in Longmont and Frederick. Tim is a 59-year-old doc that worked in small town Iowa for 25 plus years, seeing 40 or so patients per day, working 80 hours a week, doing OB, 800 babies, doing ER on the weekends, and being a hospitalist for his patients in small town Iowa. So the classic Midwest primary care doc, and I'm from Nebraska. And Tim, he wanted a different way. He went to a direct primary care conference. He'd been coming to Colorado with his family for years, and he had a home in Estes Park, and he said, essentially, I want to do DPC. He found us. I interviewed him on one of his trips out to Colorado. He sold the farm back in Iowa and moved his family out to Colorado, and now Tim, who works 4 days a week from 8 to 4 or so, 4 days a week, sees 10 patients a day, give or take, right? 10 to 15. One of our physicians we just hired was asking Tim, hey, how does it feel working at NextEra? He's like, I feel like I'm semi-retired. You know, so many of us that have been working in primary care for years have those kind of stories. The last thing we'd want to do is make our lives more complicated.
So I'm going to just give a lot shorter answer, but that's because we haven't been operational as long as Clint has. But I agree 100% that primary care doctors should make in excess of $200,000 a year. And where Hip Nation is built around a direct primary care model, which is based on everything that direct primary care is. A small panel, time with patients. The frustration for many of you out there is being able to get your patients seen by specialists. And we feel like we have the secret sauce of how to put that all together and work with specialists. It's better for the patients, it's better for the employers if you have communication between the primary care doctors and the specialists, so that when you have a patient in your office with a rash and you call up the dermatologist who is part of the Hip Nation ecosystem, and you say, listen, I'm shooting you a picture, tell me what you think, and you take a picture, and then you get the dermatologist who really wants to keep the patient out of their office and reserve the appointments for patients who really need to come in, say, oh, you know what, that's easy, just treat this way, call me next week, shoot me a picture next week, we'll see if we need to have them come in. It's better for the patient, saves money for the patient, saves money for the employer if they're self-employed, it saves time off from work. So this is really I think the secret sauce to make this whole, what these guys are doing is the nucleus, and this is, I think, the rings around the nucleus.
Yeah, so I agree 100% with Hal and Clint. And essentially, for the Dive and Direct Care ecosystem, we don't touch the money, so that all goes through Acressa. And we're just the connectors. We're the glue. We want to connect everyone and make it easy and seamless to fill practices.
So my name is Dino Ramsey, work in the same community as Steve. And I have a couple of things. I've got the public health background, so there's a lot of different perspectives we can take here. There's certainly the physician, the professional perspective. There's the employer's perspective. You can certainly look at the system and the policy perspectives. But from a public health perspective, I want to see the communities themselves get healthier. So I'm kind of wondering about when you do an on-site clinic versus sort of a community-based near-site clinic, then an employee who leaves a company theoretically will not be able to use the on-site clinic. I'm kind of wondering if you could address that. I do have a second question, if you don't mind. I'm just going to keep going. I recently had the pleasure of meeting a vice president of an insurance broker who happens to be an epidemiologist statistician. And we started going through how to identify the data that is actually scientifically valid. Now, not to a business level, here's your expenses last year, here's your expenses this year, we saved you 25%. But where the population's the same, are they differently motivated? Are they, is the age and gender distribution, or is their motivation different? And you gotta start breaking, and the costs, there are some costs that are really not addressable by primary care, like catastrophic events from, a neonatal incident with an ICU stay of multi-million dollars, and you've got to back that out, and then you've got the cancers that just happened and maybe are not immediately addressable by primary cares. Primary care's got 10 or 15 year lead time before prevention's actually effective. So it's actually that much more complicated. I'm kind of looking at the data that everyone's collected, and everyone's presented some degree of collecting data so that the employers and the brokers are happy. But where do we have the real, scientific policy push that we can actually say that, related to my first question, we're really improving the health of these communities that we're involved in?
I'll take the first question.
I'll take the second. I'll take the second.
So first question, so on-site versus near-site. So if you're an employee and or the family member, they can come to that on-site clinic. If you leave as an employee, what we do is we'll have different rates depending upon the size of the employee. So we guarantee for at least a year to sometimes 18 months that employee and their family, we guarantee them their next tier rate. And these clinics are typically, 10, 15, 20 minutes away from the employer. So patients in, let's just say, the Boulder, Denver area just go to our clinics. And that's kind of the cool thing, that even when they leave the employer who's paying for the benefit in full for some of these employers that we work with, they come on and stay on Nextera, which that's part of the, are we providing them value? Now, we've never had a patient complain, hey, I just quit my job at, Jim's Automotive and I can't use the on-site clinic anymore. It'd be a little awkward too, but we have near-site clinics. So it's a value add for those employer groups. Now, granted, these are employer groups that typically have more than 500, 600, 700 employees. One of the sites that we're at, they have like 1,000 employees on that campus, and HR has told us it's their best recruiting tool. So in our area where unemployment's about 2.4%, they walk potential employees or employees are just hired by our on-site clinic. And so that's kind of cool. And again, guys, we do that at zero because when you look at the overhead, they're paying us a check every month for all the members. So we can cover that on-site clinic. We don't charge them a dime for that. Much different than a lot of the existing on-site clinic models.
So the answer to the second question, you know, the data is something that takes years to generate, and it's not robust. And none of us here are saying are coming up with data that's different than what all of you can come up with in your practices. And it's good, the numbers that I presented, 94% less emergency room visits, decreased smoking or increased smoking cessation. That's all data that has been published. It's scant, but it's data that's been published by doctors who've done DPC practices. And as time goes on, and groups like Clint and James, who have large numbers of direct primary care doctors, actually look at that, and that's easy to look at, that becomes, you know, a body of evidence that then you can put together.